Good afternoon. I'm Jeff Kahn. I'm the new director of the Berman Institute of Bioethics as of July 1. It is my distinct pleasure to welcome everybody to what is the first of the Berman Institute seminars for the year. To remind you all, you're all here, so you probably don't need reminding, but we have seminars every other Monday, starting obviously today, and in 2 weeks' time, Mark Rothstein will be here speaking. We have our full schedule posted on the Berman Institute website. So while you get settled and get your food, let me do a very quick introduction of our speaker today. I'd be pleased to be able to welcome to Hopkins, back to Hopkins, having been here not so long ago, Scott Kim. Dr. Kim is a senior investigator in the Department of Bioethics in the Clinical Center at the NIH, as you see from the screen. What you don't see is that he's also adjunct professor of psychiatry at the University of Michigan and adjunct professor of neurology at the University of Rochester, places he was previously on the faculty prior to his coming to the NIH. Scott received his MD from Harvard and his PhD in moral philosophy from the University of Chicago. He also trained in adult psychiatry at Mass General Hospital in Boston. Kind of okay in his training, I guess we'd say. He combines philosophical, clinical, and empirical research approaches to his scholarly work, using a variety of those methods, both empirical and normative, to assess and address a range of bioethics topics, including decision-making capacity, surrogate consent for patients who lack capacity, theories of informed consent, end-of-life issues, and research ethics. He's a good friend. We have worked together on various projects. I can attest to his hard work and great insights, and it's really great to have him so close in Bethesda. We have gotten him up here, maybe not for the last time, hopefully, given his proximity and the interests that he shares with many of our colleagues. Today, Scott will be talking with us about euthanasia and assisted suicide for psychiatric disorders, ethical and policy implications. Please join me in welcoming Dr. Kim. Thank you, Jeff. Can you hear me? Great. Can you hear me now? All right, because I hope to maybe walk around if I can. So it's an honor to be here. As Jeff said, I have been here before, but it's been a few years. And I've always wanted to visit your spanking new bioethics center, which is quite beautiful, and a couple blocks down, and that was really nice. Well, today I'm going to talk to you about what sounds like a little bit of a downer topic, which is death, euthanasia, and assisted suicide. I hope I'll make it interesting. What I'm going to do, there's certain slides I have to go through. My collaborators and some of the work that you'll see. And this is a reminder that I'm not going to spend a lot of time explaining the terms, except that when I say euthanasia, I mean voluntary active euthanasia. Assisted suicide, I'm just going to rely on your intuitive understanding of that term unless somebody asks me. But I am aware of the fact that many people are uncomfortable and feel that those are stigmatizing terms, and so other terms have been proposed, such as physician aid in dying, hastened death, medical aid in dying, because in Canada, where the practice is legal, nurse practitioners can actually assess for and perform euthanasia or medically assisted death. I'm going to use the term EAS, euthanasia, or assisted suicide, because that is the dominant term in the research literature and is the accepted legal term in Netherlands and Belgium. And that's where most of the data I'm going to discuss today comes from. Okay, but I will sometimes use the acronym PAD, or physician aid in dying, as well. The focus will be on psychiatric EAS. By that I mean providing euthanasia or assisted death where psychiatric disorder is the primary indication. is such a issue at the crossroads of this debate generally. And I'm going to then talk about what people think about when they hear this topic about psychiatric euthanasia, the typical case that people have in mind. The bulk of my talk will be actually giving you an old-fashioned, public health or medical center talk on the data. What has the experience been? And then we can have discussion. All right, so I'm going to now do my 100-meter sprint through the background. Some of you, or hopefully most of you know, there are several jurisdictions around the world that have legalized some form of assisted death. In the US, 4 states have laws. 1 state has a legal ruling that makes it permissible. The bolded countries are the countries where it is legal to perform some type of assisted death where the primary indication is suffering from psychiatric disorders. In Canada is important because that's the latest country. In fact, in the middle of June, they finalized and enacted a law that made euthanasia and assisted death legal in that country. This is a very active area of debate. I think in 2015 there were 25 state proposals, for instance. Only 1 passed in California. And there are an increasing number of people receiving assisted death where it is legal. So this is Oregon. It was enacted in '97, so you see that numbers are still small. 132 people died directly from ingesting a drug that was prescribed. This is the trend in the Netherlands. You'll see that in the last few years, the slope has become quite steep. So it's about tripling in 9 or 10 years. And the number is about 5,500 as of 2015. Just so you know, if this were happening in the US by per capita ratios, it would be about 100,000 maybe people who would be dying of euthanasia in this country. So that would actually be quite a few more than people who die of diabetes every year in the US, and somewhat less than people who die of strokes. This is the trend in Belgium, and you just have to look at the top line. The number is especially, the slope is quite sloped there because the reporting is increasing as well as the number of cases. And this is probably still an underestimate because the reporting has not been as robust in London as it has been in the Netherlands. As I say, most of the cases are very sick people in terminal stages. So you can see that out of the 5,500 cases in the Netherlands in 2015, 4,000 were for cancer. And psychiatric cases are made up of only 56. So from a proportional perspective, it's very low, about 1% of all euthanasias. Now, when I say euthanasia, I mean both euthanasia and physician-assisted death in the Netherlands. But you'll see that the slope is, on the upward. And per capita equivalent in the US would be about 1,000 to 1,100 people. So imagining in the US about 1,000 to 1,100 people receiving euthanasia or physician-assisted suicide if it were legal here. So that just gives you a proportional sense. In other words, many people know people in the Netherlands, even the numbers are small. Okay. In Belgium, where the cases are not broken down into psychiatric versus non-psychiatric, they tend to break it down into diseases and also in terms of terminal, non-terminal. And you'll see that the non-terminal cases have been rapidly increasing. So in 2013, it made up 15% of all euthanasias in Belgium. Okay, so that was my quick run through the background. How many people have seen or read or heard about this article? Just raise your hand. Okay, only a few. So I would highly recommend this New Yorker article. Like virtually every article you read in that magazine, it's extremely well written, and it gives you a very good feel for sort of cultural context in which this this is a far off possibility, I just want to point out that last year, after the California law was passed, the NPR website had an article, the title of which was, "Despite sweeping 8 and 9 law, few will have that option." And as you can tell from the title, the entire premise of the article was, it's well and good that they now have this law, but it really isn't going to affect lots of people who need it. And they interviewed people who said, well, look, for right now, this might be the best way to go, but in the future, we hope to push for expanded access. So I think in the US, this will also become an issue of psychiatric euthanasia. And just across the border in Canada, as I said, when this was passed in June, that followed about 16 months of debate after a Supreme Court decision which de facto made it legal. And during that time, there were 2 very influential reports which really clearly advocated having an expansive regime which would allow euthanasia for psychiatric disorders. And also there was a court case that went to a regional appeals court which also said that. But Trudeau's Liberal government rejected that view, and they passed a law that fairly restricts it to as an end-of-life issue. So people with generally medical or neurologic illnesses who are facing death. Still, the law does require initiation of the study of this topic plus a couple other topics by the end of this year. And within 2 years, they have to report back to the Parliament. And there are already lawsuits being filed. So this will, the constitutional question in Canada is not settled by any means. So it's not so far away from where we're sitting. And from a bioethical, philosophical point of view perspective, the issue of psychiatric euthanasia is particularly interesting because it sits at a crossroads. And first, in relation to this question, if euthanasia and assisted suicide is to be legal, as we have in 5 states in this country or in other countries, can you justify limiting it to just terminal illness? What is the justification for limiting it just to people who have terminal illness? That's one question. Hotly debated in Canada. Just to remind you, there was an influential article in the England Journal in the mid-90s in which the authors, who are well known in bioethics, who raised this question and said, look, there's no reason in principle why we should limit it to terminal illness. I guess I should add, in all fairness, Frank Miller recently wrote an article reversing his view on that particular issue, but that was the view in 1994. Now, the second crossroads question is this: if psychiatric euthanasia is permitted, why do you need a medical reason at all? Or why do you need a rationale at all? So I think these are interesting things that you can discuss in your philosophy classes maybe, but they have become public policy debates, actually. And the only reason I point this out is because the rationale with which you justify the legalization of practice will have an impact on where you draw the line. Okay. Now, for today, I am not going to talk about the philosophical pro-con arguments. Usually those would go along the lines of people with implicit or explicit commitment to some broad theory like consequentialism or Kantian view or natural law theory, plus or minus what philosophers call reflective equilibrium, which is people arguing back and forth, testing out cases and trying to arrive at some stable consensus. Now, or view. We're not going to do that. What we're going to do today is to ask the policy question, which is, let's take the issue of, okay, we're going to legalize this, or these are the arguments for legalizing it. What are the relevant policy arguments? And obviously one of the most important is just this issue of understanding the impact of that proposed or actual policy to see if the goals of the policy are met, right? So that's the framework for the rest of my talk today. What I mean by a paradigm case of psychiatric PAD or euthanasia is that if I ask somebody, oh, have you heard of the debate over, allowing euthanasia for psychiatric disorders? People usually have a mental picture of what that patient must be like, what they're suffering. And it typically is, and philosophers tend to focus on this type of case, which is a person with treatment-resistant depression. The phrase I took from one of the articles is suffering greatly and permanently. So there's certain built-in empirical assumptions there of a competent, informed adult making a well-considered decision. So actually, even though I have 3 points, you will recognize people who have some background in bioethics will see that the first is a suffering condition, and second is an informed consent. Second and third constitute an informed consent condition. Okay? Now, added to this is the hope and assumption that doctors can validly and reliably determine those criteria when they evaluate patients. And of course, that the oversight system that you built into it will be robust enough to make sure there aren't abuses, neglect, or errors and things like that. All right. Now, so that paradigm case and the requirements of when it would be okay is, of course, reflected in the laws of the lands in which this is legal. So this is in the Netherlands. They call this the Termination of Life Unrequest and Assisted Suicide Procedures Act. This was passed in 2002. Of course, the practice was legal for a couple decades preceding it, but this is when it was actually made into formal law. And they're called the due care criteria. A, the request has to be voluntary and well considered. The patient has to have unbearable suffering with no prospect of improvement. The patient is informed, and that there's no reasonable alternative in the patient's situation. And you will see that A and C go together to make up the informed consent concept. And B and D really put together make up the unbearable suffering that's permanent concept. Okay? All right. And then there's the making sure that doctors are doing a good job when they evaluate patients. As you will see, that the requirement in the Netherlands and Belgium is a little bit different than the requirement for consultation in the US for second opinions, because in Belgium and Netherlands, the requirement is actually literally that, consultation. There's no requirement that 2 doctors have to agree. So, as you'll see. And then due medical care just means that you have to perform the act competently. The Dutch system reviews cases through 5 regional committees that are made up of 3 people, a doctor, a lawyer, and a bioethicist. And the doctor is usually not a psychiatrist, and the data that I'm going to present were collected during the time when there were not psychiatrists on the regional review committees, as far as I understand. And reviews are, if 2/3 of the people, 2 out of 3 people feel that the due care criteria I just mentioned are not met, then the doctor who performed the case is referred to the legal authorities. Now, the Dutch have a long tradition of transparency and getting things out in the open. I am not a sociologist of culture or anything like that, and I don't speak Dutch, but there is a certain Dutch terminology and a kind of cultural concept that speaks to this, where they feel that keeping things under the rug, so to speak, is a very bad thing, and the good thing is to get it out in the open. So there's a real commitment to making things open. So these committees publish cases that they feel are educational. They could be controversial, or it illustrates a point, or whatever. And they use the term common law. meaning as an analogy, meaning they publish these cases so that doctors and others can read them and see how the due care criteria are being interpreted. As you saw, those due care criteria, you might wonder, oh, surely each of those criteria must have subparts that describe what they mean. Actually, there isn't. That's all there is. That is the direct guidance provided for doctors when you evaluate patients. So that's why they feel that they need to publish these cases. And they're based on the submitted medical records and other documents. They generally are about 2 to 3 single-space pages. So, quite a bit of information. Some of them go on to 8, 9 pages single-spaced, and they give you a lot of stuff in detail. And when we reviewed the psychiatric cases as of June 1, 2015, there were 85 reported cases total between 2011 and 2015, and they had actually published 66 of those. So, clear majority of them. And we thought that was a good opportunity to study these to find out what's happening. Now, there are limitations because this isn't the entire case file, but they are written by the committee. But it's relying on self-report of the reports submitted by doctors who performed the euthanasia. And these reports are written after the committees have reviewed the cases. So, you have to take it with that caveat in mind. Okay. So we published a couple of papers looking at those cases. And let me just go through what the patients look like, how the physicians implement the criteria, and how do the review committees actually evaluate these cases. So, majority, and this is not just in the Netherlands, this is also true in Belgium, a clear majority are women who receive euthanasia for psychiatric disorders, 70%. What's interesting is that this is about the ratio of women to men of suicide attempts. So men commit suicide more often than women. That's true in virtually every country in where it's studied. But the attempts are greater in women than men at about this ratio. So that's an interesting finding. The age groups here, the Dutch group who received this psychiatric euthanasia are younger, somewhat younger than the general population who received euthanasia in the Netherlands. However, the group in Belgium, I don't know if I have time to go through that, is much younger. Personality disorders are quite prominent, as you can see, about over half. Over half have had history of previous suicide attempts. 80% have had psychiatric admissions in the past. And I'm going to just elaborate on the social isolation feature a little later on. In terms of diagnoses, it shouldn't be surprising that the most common diagnosis is indeed depression. So 73% of the people had some diagnosis of depression, unipolar, bipolar, psychotic depression. But people had a lot of psychiatric comorbidities as well. So if you look at the parentheses, that's the percentages, but the denominator is the total number of diagnoses. So don't use that as the percent of people. That's not the right number. In terms of percent of people with different diagnoses, what I found somewhat surprising, over a quarter had some type of a psychotic condition. So, and out of the 17, about a little over half had a chronic or some type of, like schizophrenia, schizoaffective disorder, and about 8 had depression accompanied by psychotic symptoms. There are other interesting factors. Anxiety disorder is very common, especially people who've had PTSD and some type of really active residual symptoms of traumatic events. There were also diagnoses I hadn't anticipated, such as prolonged grief, as you see toward the bottom, autism. And I'm going to I'm going to read a little bit in detail of 5 cases so you get a feel for what some of these cases are like a little later. Okay. Comorbidities were very common. I'm not going to go through in detail. Social isolation and loneliness. I emphasize this because this was a very commonly described situation in these reports written by essentially a bureaucratic committee, but they noted this as a common feature. So, two very striking, among many quotes. The patient indicated that she had had a life without love and therefore had no right to exist. The other patient, was an utterly lonely man whose life had been a failure. So there's this sense of people who are kind of gloom. I mean, as you can imagine, we're talking about helping people die. But it was quite striking to see some of these quotes. Now, most had extensive psychiatric treatment. In the Netherlands, the healthcare system is much more accessible than it is in the US. They do have private-public components, but in none of the cases that I read, 66 cases, was there ever even a kind of an implication that somebody didn't get something because they were worried about the cost. I mean, in fact, for a psychiatrist to read case summaries where cost doesn't come up as an active issue is like amazing. You know? So to read 66 cases in which that's not even mentioned is quite impressive. So people got extensive treatments. But 48 patients, I said, out of 66 had some form of depression. What we found striking, though, was that ECT, which is the most effective treatment for depression, 26 people out of 48 received it. So that was fewer than I had anticipated. What was really striking was that only 7 people had mentions of having received MAO inhibitors. This is a very old class of drugs, but even today, psychiatrists, when you're treating people who have really difficult to treat depression, at least try this class of drugs, because there's some evidence that for really serious cases, they can be more effective. And I have the parentheses "at most," because we coded this very, very conservatively in the sense of, it said the patient was tried on every medication on the depression protocol. It doesn't mention MAO inhibitors, but we counted that as the person having had received it. So even with that coding, only 7 of the 48 patients actually went through it. What was common is that clearly a majority of people refused treatment as part of their assessment of futility of their disorder. So in 18 of 37 people who refused some form of treatment, there was no motivation. They just lacked motivation to try it. They were afraid of side effects and doubts about efficacy. And people had more than one reason. Now, one of the striking things is that 1 out of 5 people never had psychiatric admission. So in the US, even with our very poor mental health care system, if you have chronic suicidal, or attempts or things like that, or very serious illness, it's fairly predictable you will have had at least 1 admission in the past. So it was interesting, in a country where this was much more accessible, there was 1 in 5 had never been hospitalized, according to the notes. Okay. In terms of decision-making capacity, I'm just going to run through this very quickly. What was interesting is that we coded the discussions of how were these people evaluated for capacity, or how did they talk about the person's capacity in these reports. And this is, of course, limited by the fact that these are summaries of the cases. However, this is one of the most talked about criteria in this debate about psychiatric euthanasia. What we found interesting is that in over half the cases, the only time we see a reference to capacity is simple statement: the doctor evaluated and found the person competent, period. Or doctor found the person incompetent, disagreeing with some other doctor. So in over half the cases, that's all we could find. Now this was, I think, for many of those cases, it's because we do practice presumption of capacity in adults, unless you have a clear reason to doubt it and have to evaluate. What was interesting is that out of the 34 people for 7 had psychotic symptoms. So in those cases, generally, you would try to provide a little more justification. So whether the committee felt that it wasn't necessary or the doctors didn't perform it, either way, it was not a high priority item in these reports. And in 4 of the cases, there was disagreement among psychiatrists. And that's all it said. And I'll describe those cases in a bit. In 17% of the cases, you had a little bit more, which was, instead of just saying competent, not competent, you might say the person can understand things, therefore competent. Or a person can reason about things without describing exactly what they could reason about. In a third of the cases, there was some evidence describing why, what, and how they understood things, for instance. But in only 5 of 66 cases were mention of all what we could go for relevant abilities, which I'm not going to do for interest of time. These are, in the US, often called criteria for capacity. Even the Dutch cite those criteria. They use the term Applebaum criteria because Dr. Applebaum, who is a very well-known forensic psychiatrist at Columbia, originated these 4 criteria. And both the committees and the doctors use that term. But only in 5 cases do you have all 4 abilities mentioned. In 8 cases, there was disagreement among the physicians involved. In 2 cases, at least one physician said, I'm not sure if you should get another consultant. Now, what was interesting, out of the 8 disagreement cases, there was this pattern, which is interesting. They only consisted of simple statements of competence, non-competence, without explanation. The person who performed the euthanasia was a psychiatrist. The person disagreeing was also a psychiatrist. The doctor who performed it, after the disagreement, went to another doctor to get us another opinion. That doctor was a general practitioner who said, I agree that this person is competent. After that, the euthanasia is performed. The review committees don't discuss this question of disagreement. So it's kind of, we don't know how it was resolved. It was just simply in favor of the person who performed it. Other observations regarding mental capacity. Patients can fail a criterion and be deemed competent. Now, this is not theoretically out of place. There are cases in which when there is obviously you have evidence to think that the choice they're making is very much in their interests. And if you put a really high threshold, that's not really appropriate in that clinical context. So that does happen. In this case, that's what they seem to use. So, for example, there was an instance where a doctor says, well, he doesn't meet this criterion, but I think overall he's competent, for instance. Or you might have 2 consultants agree that the patient is competent, and this is an interesting case. The first doctor says, I'm very impressed by her ability to weigh the pros and cons. Really good reasoning. But the other consultant says, well, the person's competent, but she's really poor at using reasons. So you have these kind of internal discrepancies as well. And there's a strong emphasis on repeated and persistent requests for euthanasia as a very important criterion. Okay, I'm going to briefly describe 5 selected cases to illustrate a range of cases and highlight certain themes. Okay? So this is as close to what you might call paradigm case that people think about. This is a relatively young man, 40 to 50. I say that because I would have said an old man 20 years ago, but now I say relatively young man, 40 to 50, who had 25 years of recurrent severe depression, all available treatments with only temporary results, and really, as a psychiatrist, a very recognizable patient, suffering tremendously. And he had not attempted suicide or planned suicide because he didn't want to burden his family. So this sort of person fits into the paradigm case. But then there are people who really I hadn't anticipated. Here's a woman in her 70s who several years before made a pact with her husband that they wouldn't were together, they believed that it was a waste of time to spend time with anybody else, even at parties or receptions, and they were totally focused on each other. She felt abandoned, and life was a living hell, and life had no meaning for her without her husband. They tried treatments, even antidepressants, which it's not really a proven treatment for grief, but counseling certainly had no results in this case. The first consultant said this: if the patient wanted to die in a controlled, humane manner, if that was not possible, she would commit suicide. This was not a threat, but a fact. It's interesting, that quote, because for psychiatrists, we trade and statements that mean the opposite, if you see what I mean. So when I read that, I think that's a doubly threatening threat, so to speak. Okay. However, the patient did not feel depressed at all. She ate, drank, and slept well, and followed the news and undertook activities. Second consultant said this: it's never possible to be absolutely certain if pathological grief will disappear. Her recovery seemed less likely. I mention this because this is the threshold he used to determine whether she had a permanent condition. The case of due care not met, this was a case of a person who had long history of ECT for depression, which had worked with some effects. But during this episode, she refused it. Things weren't getting better. She was tired. I don't want any more treatment. It was interesting that her own PCP refused euthanasia, and she registered at the end-of-life clinic. In Dutch, the acronym is SLK. And basically, this is a mobile euthanasia clinic staffed by a doctor and a nurse that is funded by the largest euthanasia advocacy organization in the Netherlands. So they are clinicians who comply with the due care criteria, but their explicit purpose is to really provide the services when patients' doctors refuse to evaluate and provide it. And this is what happened in this case. What's interesting is this: the doctor who saw this patient was not a psychiatrist, didn't consult a psychiatrist, didn't interview the patient alone. He interviewed the patient twice before he provided euthanasia, always with her children present. But he had not a single doubt about the clinical futility, competence, or other criteria, regarded depression as a chronic disease, and didn't see a need to involve a psychiatrist. And he had never heard of the Dutch Psychiatric Association guidelines, which explicitly tell you what you need to do. And he said that wasn't really necessary. What was striking, of course, was that the consultant, the official consultant, agreed with him, and euthanasia went ahead. The SCEN refers to an organization of consultants who are especially trained to be consultants for these situations. Patient with multiple problems, and I included this case mainly to illustrate the issue of cognitive issues, but also personality difficulties I mentioned in the earlier slides. So this person had persistent personality problems with severely debilitating somatic problems, but also had had a stroke and had some intellectual disabilities and impaired memory, and actually at the time of evaluation and euthanasia was under a guardianship. Patient was paranoid, anxious, dependent, and self-centered, continuously in conflict with people, which caused the family to drift apart. She required constant counseling, guidance, care, a very high maintenance patient for healthcare providers. Physician didn't want to do euthanasia, her own doctor, so she went to the end-of-life clinic where she received euthanasia. Here's a case of a woman in her 70s who had schizophrenia since childhood, who in her head was continuously occupied by voices, commenting on everything she did. She felt like she was staying in some sort of a labor camp and was possessed by the enemy. Her primary doctor nor her psychiatrist would agree to euthanasia because this was too complicated. She went to the end-of-life clinic. This is a case where the only discussion of her decision-making capacity is a simple statement: the person was competent. Okay, I see I'm going to run out of time, so I'm going to run through some more slides, and I'll skip some. Prior history of euthanasia refusals. So in a third of the cases of the people who eventually received euthanasia, they had been refused it in the past. 18, most of them ended up going to this mobile clinic to receive euthanasia. And at those mobile clinics, the doctor's team knew the patient less than 3 months, and in the rest of the cases, it was less than 1 year. And this just shows that there's a rising number of these SLK cases in the Netherlands, especially within the psychiatric group. 41% of the physicians who perform euthanasia for the indication of psychiatric disorder are GPs. So they're, or psychiatrists, I'm sorry. What I meant to say is that majority, about 60% are GPs. In half the cases, what's interesting is that there is more than one official consultant. By law, they only need to consult one other doctor. But you'll see there is a handful of cases, there are 2, 3, 4 doctors all involved, giving their opinions. Which goes to show that, doctors are genuinely, I think, struggling with these very complex cases. The independent psychiatrist involved as an official consultant, as required by law, was in 60% of the cases. And at other times when there's another psychiatrist involved, it's usually as a second opinion. They weren't necessarily independent. And in 7 cases, there was no independent psychiatrist at all. Disagreement in about a quarter of the cases, actually, there was a disagreement among the doctors involved that not all the criteria are met. Rarely in the case of unbearable suffering, most common in terms of whether you can still provide effective care. So the futility question. And as I mentioned, a competence question in 8. Interestingly, the pattern in 8 of these 16 cases were similar to what I mentioned before. The psychiatric consultant says, due care not met. GP consultant is the next consultant because technically the physician could have just gone ahead, I disagree, I'm just going to proceed. But usually, they seek out another opinion. In this case, GPs agree with the initial doctor who wants to perform the EAS, and then it proceeds. The committee's review process and some of the results is interesting. Out of all the cases, thousands and thousands of cases over the years, there's only been 0.1% that have been deemed to have due care criteria not met. So 0.1%. And most of those are technical things like, was the consultant independent? Did they use the right medications? It's almost never the case that they challenge the case of determinations of competence or futility. In Belgium, there's only been 1 reported case out of 8,000 cases of euthanasia where a doctor was deemed not to have performed the due care method. The committee seemed to allow practices by doctors that are less kind of rigorous, so to speak, than the Psychiatric Association's recommendations, which don't have any force of law, they're just practice guidelines. Although this may have changed in 2015. I'm not going to go into that detail in just the time. Now, what I found interesting was that in these reports, there's really no, especially complex cases, you might have the committee calling other doctors in and interviewing them and so forth, but often, even when there is a clear disagreement, they defer to the judgment of the doctor who performed the EAS. I'm not going to talk about, I have a few slides in the Belgian experience, maybe if it comes up I can talk about that during but basically there's very little evidence. There's only 1 paper by this doctor who is a well-known advocate of psychiatric euthanasia. That's her book. And she reported on her 100 consecutive cases. And, I give you some data on that. But we can talk about that later if there's some time. So I'm going to conclude with this couple slides, which is, okay, Dr. Kim, you said that you're going to focus on policy. And policy only matters if it's going to affect lots of people, right? If it's only affecting 56 people in a country of 17 million people, that's really not a big deal. I think that's a pretty strong argument. So, I think it's worth thinking about this from that perspective. Why are the numbers small? Is it going to stay that way? So that's how
And even among the public, there is lack of approval. So there's still a negative attitude toward it, and I think that accounts for why so few people are currently euthanized. This situation will likely change for the following reasons. Physician supply is increasing and will continue to increase. Entities like the end-of-life clinic I mentioned to you, these are mobile clinics. And also there are specialists who spend their professional time evaluating and providing services regarding this class, like the doctor I showed you the picture of there. And there is now increasing recognition that there is societal, family, and other pressures on doctors to be not so limiting in their evaluations, and that laws are more liberal than the doctor's personal limits. So this is causing lots of discussion. The patient demand, I think, will go up for the following reason. There's a very large pool of chronically ill psychiatric patients with prolonged periods of sustained desire for death. Unfortunately, it's not uncommon. In fact, there are in the U.S. there are 1.1 million suicide attempts per year. If only 10% involve people with chronic illness with which to die as persistent, you're talking over 100,000 people. So in the U.S. So analogously, I mean, this is a small problem now, but as it's becoming more socially accepted, doctors in countries where this is legal will have to think about this more. So maybe we could end with this discussion. Is this regulatory system that I've briefly examined, which I believe the conclusions we can draw is that unbearable suffering is a fairly permissive criterion because it has to be defined subjectively, so it's what the patient finds unbearable, and this is sort of written into the interpretations. Futility can include treatment refusals, and that was written actually in the terminal in this context, which made a lot of sense because by then there's no effective treatment. But that, in the psychiatric context that you saw how it's applied, capacity throws are not intended and used as a high threshold. And disagreement among doctors are accepted, and the review system is based on retrospective review of physicians' reports. So it's an interesting issue where most of society in Netherlands, it's interesting, that are against this. But the system seems to be geared toward to ensure that people who want it can get it. And this is good public health building, right? So, as you know, when you increase sensitivity, you sacrifice specificity. So it's an interesting question. Thank you.
Thank you, Scott. So I think we have microphones to row. We do. So Emmy has one, and I guess I have the other. While we wait for Emmy to go to Deborah, let me ask you one observation and maybe ask you to describe. So one way to answer patient demand is through what we might call euthanasia tourism. So Switzerland has two organizations, one of which allows foreigners, I forget which one it is, Dignitas or Exit. So do you see that as another growing trend?
There are beginning to be reports of a lot of people going to Belgium.
For that, and that's permitted within the Belgian policy.
I'm not a specialist in European, but as you know, it's gotten recently quite complicated with Brexit and all that. But there are certain commonalities that they share in terms of regulations laws, and I'm not sure. The European Court of Human Rights actually had made a ruling on a Swiss case, which said essentially permitted psychiatric euthanasia.
I guess the question is, how many outlets do there need to be for the numbers of people? But it presumes they could get there, obviously. Yeah, no, it's an interesting.
Yeah.
Okay. Yeah.
Hi, Scott. So is this on? Yeah. You can hear me? Okay. That was a really, really interesting talk. So you ended with, can a system with these features be a sufficiently safe system? Is there a sufficiently safe system? Do you think there can be? You never really answered that question.
it will depend on what your ethics is to see what kind of policy is tolerable, right? There are people who really feel that this is a human right and feel that people shouldn't have to justify why they want their lives ended with help of somebody else. For those people, the Dutch and the Belgian system is too restrictive, and that the damage it's causing from their perspective is that it's not free enough. As a clinician, I mean, I'm sure you could tell, this has a very fundamental impact on what the nature of mental illness is, what the role of a healthcare provider is in that context. The pro-euthanasia perspective tends to see psychiatric disorder as a highly medical illness. So we diagnose you with this, we have treatment, it doesn't work, therefore we should treat you just like people with medical illness. That's one of the most potent arguments for that. As a psychiatrist, I think that's, although our system we're getting pressured to think that way, it's a little bit more complicated because the very nature of the mental illness, I think it's a reasonable thing to say it affects how you make decisions, who you are, and you can conceive of a situation where what people are asking for when they come see a psychiatrist isn't simply just take away this pain, but also, can you help me live with this pain? And if that second role is not the role of a doctor, I can see why you might have a different view. So that's a long answer to, it does affect what your ethical perspective is before you think of the policy.
Can I ask one follow-up question about the mobile clinics?
Yes.
Because it does seem, I don't know if it's the case, there's a data question about, are there a higher proportion of folks with psychiatric disease who end up with the mobile clinics as opposed to through the normal path?
That is true.
That is true, okay. And are there any efforts or mechanisms to constrain or improve enforcement of policy on mobile clinics?
Well, remember, your question kind of assumes that people have to see it as somehow inappropriate.
Right, yeah, no.
So, I would have to say that the Dutch and the Belgian systems tolerate quite a bit of what we might from the outside see as conflict of interest. So, for example, on the Belgian Review Commission, which is actually, instead of 3 people in 5 regions, they have one central 15 or 16 member review committee. And over half of those people are affiliated with some type of, activity or officially with pro-euthanasia activity. So if you read the New Yorker article, she spells that out a little bit in more detail.
I'm told I don't need a microphone, but I'll take it. Thank you, Scott. The mobile, I want to follow up related to Deb's question about the mobile clinics. I don't know anything about the healthcare model, but here I'm almost equating the mobile clinics to the rise that we see in these urgent care express centers, the kind of dock in a box. Are the mobile clinics in the Netherlands, do they exist also for non-psychiatric conditions? And one would think almost, is this a carve out? Because I have patients who go to the mobile clinic because they don't want to have to go to the ER, they don't want to wait, valid reasons, but then there's the argument about the level of care and who's providing it. You brought up the whole issue of who is working in those. Can you tell me just a little bit more about
Yes.
the mobile clinic?
So it is designed specifically to meet a need from their perspective. And the need is for those patients, regardless of their disorder, who would otherwise qualify for euthanasia under Dutch law, which is, interpreted, of course, to receive it when they've been refused, or if they would rather go directly to them. But certainly come to us.
Thank you.
Thanks, Scott. That was really interesting. I want to ask you to expand on one of the cases that you talked about, kind of your view of that case. And I think it's going to mean that I want you to answer the questions you said we weren't going to answer. But the case about the woman who was grieved because her husband had died and they signed a pact, or they made a pact, right? I don't remember what the paper is, but when I used to teach this issue in Intro Bioethics, we'd read a paper, maybe it was from the President's Commission, where they talked about the fear of things like existential angst being a legitimate reason for euthanasia. That was supposed to be the end of the slippery slope, right? That was supposed to be the reductio. And I was an open question as to whether or not that's a reductio, right? But it starts to sound like in that case, as more than any of the others, that it's really unclear to me as a non-physician, as a non-psychiatrist, whether that was a medical case at all, right? There was that really confusing line about, she's thinking clearly and she's reasoning about it and she gets along with her life and, she sleeps and eats, but she wants to die because she said this is, she doesn't like life this way. So I just wanted to hear you talk a little bit more about what your view on that kind of case is.
Yeah. Well, as Jeff mentioned, I was trained in psychiatry as well as in philosophy. Although the claws of clinical training seem to run deeper and people end up. So it's harder for me to shed my clinical perspective. Maybe that's just my philosophy. I think that in that case, and in other similar cases, what you're seeing is really the Dutch attempt to draw some type of a line. And some type of a line they want to draw is tied to something we can agree socially as a medical condition. Okay? Because otherwise, anything can go, right? And one of the things that people don't quite realize is that the Dutch system is very doctor-centric. Doctors are the gatekeepers of this whole, they get to decide who and so forth. And I think that the reason why they had to appeal to a diagnosis is because of the law requires it. I think that in that case, there may be cases like that, and other cases where it's really more in the realm of worldview about who has a right to end their life for what reason, right? And there's a similar case in Belgium where the doctor did perform euthanasia, except he didn't go through all the criteria. So that's the 1 out of 8,000 cases in Belgium that was referred to the prosecutor. And you can actually watch a 1-hour video on that case. It's called Allow Me to Die. It's an Australian broadcasting network. So if you just Google Allow Me to Die, you will see the case of Simone de Moore, where she is described very similar to the woman who was that I described. So I probably didn't answer your question. I think that I don't know. Let's just say that thinking like a clinician, I have a certain bias.
Let me save you from having to go any further then, since we're at the end of our time. Really fascinating topic and a really fascinating talk. Thank you all